because of the increased muscle mass. And I think we talked about this when we were talking about aortic stenosis the other day. There'll be increased demand. If there are other situations, like, for example, thyrotoxicosis, hyperthyroidism, that increases, the myocardial oxygen demand, that's another one. Then the other side of the equation is inadequate supply. One cause of this is, of course, anemia. I mean, it is hemoglobin that carries oxygen to the tissue. So if you have less hemoglobin, then there is less supply of oxygen. But the main cause of inadequate supply is obstruction to coronary flow. And that's why I've highlighted it. And this obstruction to coronary flow, which is coronary artery disease, is predominantly atherosclerotic. And the rest of this lecture, unless specified otherwise, will be referring to atherosclerotic coronary artery disease. There are other things that can cause coronary disease, inflammatory conditions like some of the connective tissue disorders. There can be congenital abnormalities of the coronary arteries. There can be embolization, blocking a coronary artery which is otherwise anatomically normal, etc. But predominantly from now on, we'll be talking of atherosclerotic coronary artery disease, also often called atherosclerotic cardiovascular disease. So just a brief about coronary anatomy, which you learned just the other day in your first or second year. There are two basically main coronary circulations, we call it that way. So on the left side, we have the left main coronary artery, which divides into the LAD, that is the left anterior descending, and the circumflex artery. Then on the right side, there's the right coronary artery. Then a further important point is that for the myocardium, oxygen extraction from the blood is maximal at rest. And this is different from skeletal muscle. Skeletal muscle, you can increase your oxygen extraction when you exercise. In the myocardium, it is maximum at rest. Therefore, increased oxygen demand can only be supplied by increased flow. So if there is obstruction, which means we can't manage the flow, then you end up with a deficit like we've talked about. So somebody needs to mute their speaker, their microphone rather. So I said that risk factors are important in atherosclerotic cardiovascular disease, and this is a list of the many risk factors that we have. And part of the management of atherosclerotic disease, coronary artery disease, is risk. Either it is in primary prevention, so we are stopping people from getting coronary artery disease, or in secondary prevention, they already have coronary artery disease, we are preventing progression of the disease. So among the important risk factors, one is hypertension. Two, in fact, I should change that to tobacco because it's not just cigarette smoking, it's cigarette smoking, but also other uses of tobacco. And this also includes what we call second-hand smoke. So if you live in an environment, whether it is in the office or home where somebody else smokes, then you are in trouble. And then there's the lipid abnormalities. And with respect to the lipid abnormalities, they're important because, as you probably know from your biochemistry, there are many components to the lipids that we have. So the important risk factors is if you have a high total cholesterol, a high low-density lipoprotein cholesterol, a low high-density lipoprotein cholesterol, or triglycerides. Then diabetes, obesity. We can measure obesity overall by using the body mass index, but we can also assess the distribution of fat, where it is because central obesity is more harmful than peripheral obesity. And we usually measure this by looking at the ratio of your hip, the ratio of the circumference of your hip and waist. A high waist-hip ratio is bad for you. A low waist-hip ratio is good for you, which means that if you are going to deposit any fat, you better deposit around the hips rather than around your abdomen. And diet is important. One, of course, because diet determines many of the things I've mentioned here: cholesterol, blood pressure, diabetes, but also certain patterns of diet per se are good for you and certain patterns are bad. So for example, a diet rich in vegetables and fruits is important. Psychosocial factors is one of the emerging risk factors. We've previously focused on what you might call biological things, but we realize now that stress, depression, bereavement, etc. are important factors in coronary artery disease. There's something called a metabolic syndrome. I hope endocrinologists will tell you more details about this. It's really a combination of several risk factors: lipid abnormalities, central obesity, sugar, blood pressure, etc. A sedentary lifestyle. Age is an important risk factor. The older we go, the more likely. Sex, females are protected until after menopause, then unfortunately they catch up very rapidly with men. If you have family history of a first degree relative, that is a parent or a sibling getting what we call premature coronary artery disease, which means before 55 years of age. Then again, some emerging factors is inflammatory markers, for example, C-reactive protein, markers of thrombosis like fibrinogen, and very important for those of us who live in polluted cities, air pollution is coming up as a very significant risk factor for coronary artery disease. So all these are things that we should work at, both with respect to preventing coronary artery disease, but also in people who already have coronary artery disease. So this is a slide that summarizes the pathogenesis of atherosclerosis, and then I'll show it in pictorial form, I think, in the next two slides. So this is the so-called endothelial damage theory of atherosclerosis. So you have endothelial damage from all those risk factors we've talked about. So when there is endothelial damage, as always, the body attempts to protect itself. So there's a protective response which results in production of what we call cellular adhesion molecules. What these cellular adhesion molecules do is that they attract monocytes and T lymphocytes, which then stick to the surface of these damaged endothelial cells. They then migrate through the arterial wall to the subendothelial space. Now, these macrophages, because the monocytes and T lymphocytes transform to macrophages, then take up LDL, the low density lipoprotein cholesterol, especially the oxidized form. And this forms what the initial vision in atherosclerosis is something called a lipid-rich foam cell, which ends into a fatty streak and then into a plaque. I'm sure some of this you went through in anatomy. So this is a pictorial that, explains what I talked about. So this is, up here is a normal artery with the endothelium, the intima, the media, and the adventitium. So you have the chronic endothelial injury due to the various things we've talked about: hyperlipidemia, smoking, hypertension, etc. This then is the response to injury. So you have the macrophages and lymphocytes being deposited there, you can see. And here you can see that they have migrated across the endothelium to subendothelial surface. Here, if you can see the yellow bit, that is now the macrophages taking up the LDL cholesterol, forming the foam cells. So these bits you're seeing here are the foam cells. And what you're seeing here is now an atherosclerotic plaque. So this illustrates what we said in the previous slide. And this next slide basically does the same thing, and just in a different way. So in one diagram, you see the progression rather from the initial lesion to the fatty streak, and you can see that the lesion progressing. Now you have an atheroma with, if you can see the yellow bit here, that is what is called the lipid core. And this really is just a progression to what we call a complicated lesion. Now, what happens when you actually get, that makes you get an acute coronary syndrome, we'll talk about in a few minutes. So this is the pathogenesis and progression of atherosclerosis. So now, what clinical syndromes arise from atherosclerotic cardiovascular disease? There is what is called stable angina pectoris. In fact, I forgot to change this. The more usual term, or the more preferred term right now, is chronic coronary syndrome, rather than stable angina pectoris. So stable angina, many people still use a stable angina, but we prefer to call it chronic coronary syndrome. Then we have the acute coronary syndromes, so that's chronic coronary syndrome and the acute coronary syndromes. And the acute coronary syndromes basically are of two types. I'll start with the lower one, what is called STEMI. Listen carefully here. STEMI means ST elevation myocardial infarction. And we'll address that shortly, what this ST elevation means. And then there's the non-ST elevation. So ST elevation versus non-ST elevation. And those two components there, I'll talk about in a moment. Then there are other ischemic syndrome. There's something we call variant angina, which occurs due to coronary vasospasm. We'll talk about it briefly at the end. Then ischemic heart disease can present for the very first time as what we call sudden cardiac death, which is ventricular arrhythmias. We won't talk about that because I'll confine myself to the ischemic syndromes. And it can also present just as heart failure, which again, we won't talk about because there's a lecture on heart failure. So the rest of this lecture will confine itself to the three syndromes here: chronic coronary disease, acute coronary syndromes, and a little bit about the variant angina. So let's start with the chronic coronary syndromes, which is the stable angina. So the typical presentation is chest pain. The pain, unlike what many people think that because the heart is on the left, the pain should be on the left. The pain is actually typically retrosternal, that means behind your sternum. It is typically described as constricting, feeling of pressure. It tends to radiate to the shoulder or the arm, especially the left arm, may radiate to the jaw, may radiate to the right chest, may radiate to the epigastrium. Typically, it is effort-related, so it comes with physical activity and resolves within a few minutes of rest. It may also occur at night, that is called nocturnal angina. It may be provoked by lying down, that is called the cubitus angina, and it may be provoked by any other thing that causes either emotional upset or increased oxygen demand. So following meals, anxiety, emotional stress, sexual activity. So what I've described above is the typical presentation, but life is not always straightforward. So there may be atypical presentations. The atypical presentations are particularly common in the elderly, in females, and in diabetics. And we call this anginal equivalence. So these patients might just feel, instead of pain, it may be a feeling of breathlessness, it may be vague discomfort, etc. This is something that summarizes what I've just said in the previous slide with respect to typical angina, which is borrowed, as you can see there, from the guidelines for managing chronic coronary syndromes from the European Society of Cardiology. So it tells you here that typical angina meets the following three characteristics: constricting discomfort in front of the chest or in the neck, jaw, shoulder, or arm, precipitated by physical exertion and relieved by rest or nitrates within 5 minutes. We'll talk about nitrates when we get to treatment. So if it meets these three criteria, that is typical angina. If it meets two of these three, that is called atypical angina. If it is only one or none of these criteria, then that pain is not angina. So look for another cause for the pain. It may be from the muscles, from the tendons, from the esophagus, from the pleura, from the pericardium. There are many other structures in the chest, but it's not myocardial ischemia. So going on to pathogenesis is basically increased oxygen demand. What is happening here is you have a fixed coronary narrowing, but not total obstruction. So at rest, whatever blood is able to pass through that coronary artery is sufficient for your demands. But if you then increase your demand by typically exercise, then there's a shortfall, and that is why the symptoms occur. And that's why when you stop the exercise, the symptoms go away. In terms of signs, there's really no specific sign for angina pectoris. The physical examination of the patient may be entirely normal, except if there's either complications or you might pick risk factors like, for example, high blood pressure, etc. The investigations for a patient you suspect has angina pectoris, one is an ECG, resting ECG. And the important thing here is that a resting ECG may be completely normal. So a normal resting ECG does not preclude angina because, like we have said, at rest, the oxygen supply is sufficient. However, there may be changes. There may be changes in the ST segment. There may be changes in the T waves, or there may be evidence if they have had a previous myocardial infarction. So the next level is what we call an exercise stress test. So essentially, we exercise the patient to increase their oxygen demands so that we see if we can provoke, one, the symptoms and changes on ECG. So the exercise testing can be actual exercise, which is, we use either treadmill or a bicycle, but there are people who are unable to walk. They have had an amputation, they have severe arthritis, etc. So we can also use pharmacological stress, which is anything that will increase your oxygen demands, like we use dobutamine, etc. And in terms of monitoring the patient's response to exercise, one is symptoms. Do they actually develop the typical pain? Two, do they show typical ECG changes, which I'll not go into? But then we can also make it more, if you like, complicated. Instead of just looking at the ECG, we also see if there are any imaging changes on exercise. And we can do that by doing an echo on exercise or by doing radionuclide imaging. Then, of course, part of the investigation is investigating for risk factors. We want to know whether they are diabetic, whether they have got abnormal cholesterol, etc. Then we look for any complications of the coronary artery disease. Do they have evidence of heart failure? Do they have evidence that they have had a previous myocardial infarction, etc.? The sort of gold standard for demonstrating coronary artery disease, coronary anatomy, is coronary angiography. Just one moment, please. There's some noise in my background, which is making life difficult. Let me just deal with that, and then I come back. Yeah, I think that's where we were. So I was talking about coronary angiography being the gold standard for demonstrating coronary anatomy. But in the scheme of current management, we don't always have to do it. We only do it in patients in whom we are going to intervene in the coronary arteries, and we'll mention that in the next slide or so when we talk about treatment. So essentially, the bottom line there is that there's nothing pathognomonic of stable angina, that the diagnosis is basically clinical, and it is an integration of all those things, the typical symptoms and signs, the presence of atherosclerotic risk factors, and the various investigational modalities I've talked about. In terms of treatment, basically there are two principles to the treatment of stable angina. One is symptomatic relief, so dealing with the pain, because that is what brings the patient to you. And two is what is called prognostic treatment. Treatment that does not address the symptoms per se, but address the disease process, so that you prevent progression to an acute coronary syndrome and mortality, because coronary artery disease actually kills. So how do we do this? We achieve this by one, lifestyle, extremely important. Two, anti-ischemic treatment, so that's the ones that reduce the pain. And three is the treatment to prevent events, that's the prognostic treatment I've talked about there. And then the control of risk factors. So what are the specific details of this? So in terms of pain relief, we use anti-anginal drugs. They are those drugs that we can use to stop an episode of angina that has started. And the only drugs we have for doing this are short-acting nitrates, nitroglycerin. We usually give it sublingually or by spray into the mouth, etc. And that's what we have. That's what we can do if you have a patient has got an attack of angina that is not going away. More rational is drugs that we use to reduce, to prevent the pain, so reduce the frequency of pain. instead of waiting for the pain to occur. And usually the three main classes of drugs that we use for that are, again, nitrates, but now long-acting nitrates. The abbreviations there is isosobide dinitrate or isosobide mononitrate, or calcium channel blockers, or beta blockers. So these are the drugs that we use, the patient uses on a regular basis, and will, maintain them free of pain. A number of newer drugs in the market which will probably become more established with time. I've just given you the names here so that if you meet them, you know what they are. A detailed description of this is beyond the scope of this lecture. So somebody again is having their mics on. So some of the newer drugs are Coronary, trimetazidine, ivabradine, ranolazine, etc., etc. I don't know whether the pharmacologists have talked to you about them. Then, like I said, prevention of vascular events, which is MI and death. And the two most important classes of drugs here are antiplatelet agents, usually aspirin, but we can use some of the others like clopidogrel, and statin. So all your patients who have got coronary artery disease must be on this too. Then we often also add ACE inhibitors on board, either ACE inhibitors or angiotensin receptor blockers. Then risk factor control. And then in a small proportion of patients, we might need to do what is called revascularization, which means opening up the obstruction. And this can be done by two ways. We can do it via catheter, and PCI there means percutaneous coronary intervention. So that's what PCI means. Or we can do it by surgery, and what the CABG there means is coronary artery bypass grafting. So percutaneous coronary intervention or coronary artery bypass grafting. I think that's it about the stable angina. So we'll go to the acute coronary syndromes. So like I mentioned earlier, there are two sort of, types of acute coronary syndromes, and we'll go into that. But pathogenesis is basically common. So there is what is called a plaque rupture, which is erosion of the fibrous cap of the plaque, and I'll show you a pictorial of that. And this exposes the material which is under the fibrous cap. Now, this material happens to be very highly thrombogenic. So it leads to platelet adhesion and aggregation, and then there is deposition of fibrin strands. Essentially, it means a clot forms there. And this clot then causes obstruction, further obstruction of the coronary artery. So if it's a complete occlusion, this usually ends up into what is called a transmural infarction. Transmural, which means that the infarction, the cell death, occurs across the whole width of the myocardial wall of the myocardium, so the ventricular wall. And this is what is manifested in the ECG as an ST elevation. So this is what we call ST elevation myocardial infarction. So this usually occurs due to a complete occlusion. The clot is usually fibrin rich, and that is important in the treatment, and it causes a transmural infarction. If the obstruction is incomplete, and usually these clots are platelet rich, then it causes a non-ST elevation acute coronary syndrome. So this is a pathological specimen of a coronary artery, and down here is the atherosclerotic plaque. Well, there's another one up there, but the one down is bigger. And you can see this lipid core, which looks, sort of necrotic, etc. And on top of it is a nice fibrous cap, which is covering the lipid core. So what precipitates an acute coronary syndrome is if there's disruption of this fibrous cap. And the next slide shows it. So here you have, on the left of the scope, you have a normal coronary artery. Then on the right, you have an atherosclerotic coronary artery, but with an intact fibrous cap. Then you go to the left pathway, you have disruption of the fibrous cap. So you begin to have platelets aggregation there. And then this, like I mentioned earlier, the clot propagates, forms a thrombus, and this may go on to complete obstruction, which is what gives you an ST elevation myocardial infarction. So we'll start with STEMI, the ST elevation myocardial infarction. So the symptoms really are very variable depending on the extent of the infarction. It may be minimal chest pain all the way to severe acute heart failure to cardiogenic shock. The typical symptom again is retrosternal chest pain. Well, that's a pathology, retrosternal pain, just like I mentioned for stable angina, which is usually deep, it is visceral, and like stable angina, it will most often occur spontaneously and persist. It is prolonged because this is due to the thrombotic obstruction we've talked about. These patients are often very anxious. The textbooks and actually the patients have described to me that they have this feeling of impending doom. I mean, their life is ending. They may be dyspneic. They are often nauseated and vomiting. They are often diaphoretic. They are sweating. But like I said, for angina, sometimes patients might present atypically. So it might be just hypotension, it may be just shortness of breath, etc. So you don't always get the typical retrosternal pain. And in clinical medicine, we have this term we love called the index of suspicion. So you must always have a high index of suspicion in your patients at risk because they may not always come with a typical symptom. So the signs, again, are quite variable depending on the extent of the infarction. So they may be anxious, restless, diaphoretic. If they are in severe acute heart failure, they may be cyanotic. The cardiac signs, again, may be variable. There may be absolutely nothing, but they may have a low thready pulse. Again, if they have, cardiac compromise, they may be hypotensive. They may have those features of heart failure and also palpitations in the lung, which is of course a feature of heart failure. Now, the complications in fact, we'll come back to this late. I don't know, the slides got reversed. So in terms of investigation in somebody you suspect, not you suspect has got maybe having an acute coronary syndrome, the most important thing to do first is a 12-lead resting ECG. And the guidelines is that if your system is working well, this should be done within 10 minutes of the patients being in contact with the healthcare system. So wherever they present, whether they present to an ambulance or a health center or a tertiary hospital, they should get an ECG. And the ECG is important in the sense that it gives us the initial triage. What type of acute coronary syndrome is it? In this case, if it is STEMI, there will be elevation of the ST segment. Or another way in which STEMI manifests And again, you'll be told that we will tell you the details later in the ECG lecture. They may be present with something we call a left bundle branch block. You can, I mean, that you don't have to bother too much about that. That is just another manifestation of a STEMI. The other thing the ECG tells you is the territory of the infarct, and the territory of the infarct depends on which coronary artery is blocked. And of course, the bigger the coronary artery and the more proximal the blockage, the bigger the territory which is infarcted, and therefore the less complications you expect. The ECG also tells you the evolution of changes. I won't go into details, but there are initial changes and it evolves until finally what remains is what we call Qwaves in the ECG. And in fact, previously, what we now call ST-elevated myocardial infarction used to be called Qwave myocardial infarction. And it is important to demonstrate that there is actual myocardial necrosis to make a diagnosis of a myocardial infarction. And what we use currently is serum troponin, which is quite specific for the myocardium, unlike what we used to use before, like the creatinine phosphokinase, which is actually non-specific, and therefore it is can be misleading. So in this day and age, by and large, the only cardiac biomarker we use to make a diagnosis of myocardial necrosis is troponin. Then there are other things that you can do depending on the complications and what you are looking for. Now, the other investigations are of course the usual things. You want to know whether these guys are anemic or not, what is their sugar, what is their cholesterol. Many of the drugs you use might affect the kidneys, so you want to know their kidney function. If they are in heart failure, you may do a chest X-ray, not a routine by any sense. If you are going to go to reperfusion, and we'll address that in the next slide, then of course they need cardiac catheterization. And sometimes after they recover, before they go home, you want to know if there is still any residual ischemia, so you do an exercise stress test like we talked about. In terms of the management, the most important measure, if once you have diagnosed a STEMI, is timely reperfusion. So this is absolutely important. And in cardiology, we have this saying that time is muscle. So the more time you waste, the more muscle is lost. And therefore, even after you treat the patient, the more the residual damage. The preferred treatment for STEMI, circumstances allowing, and that's an important caveat, is a cutaneous coronary intervention, a PCI. When we do it in the context of a STEMI, we call it primary PCI, which is basically angioplasty with stenting. Stenting is a stent is a wire mesh that you put where you have done the dilatation to make sure that the dilatation does not come back. Now, however, doing a PCI means you are in a center with a cardiac catheterization laboratory. You have people who have trained to do it, etc. So it is not often possible. So where it is not possible, then what we do is we give thrombolytic therapy. And there are a variety of thrombolytic agents, streptokinase, alteplase, tenecteplase, etc. And these again have got to be given within a set period of time. The moment you make a diagnosis of STEMI while you are preparing your cath lab, if you are able to, or while the nurse is preparing the thrombolytic agent in the syringe, we precede this by giving DAPT here means dual antiplatelet therapy. So we always give aspirin plus a PY2 inhibitor. The most common available is clopidogrel, but there are others, prasugrel, ticagrel, or etc. We also give, as an adjuvant treatment, a high dose statin immediately the patient comes, preferably while they are still in casualty. We also start them on anticoagulation. Usually, this is parenteral anticoagulation, so either unfractionated heparin or the low molecular weight heparin. Then additional treatments that are useful are beta blockers and inhibitors of the renin-angiotensin system, so ACE inhibitors and ARBs. Then depending on their extent of pain, anxiety and all that, so pain relief, anxiety relief, so we often give morphine, benzodiazepines, nitrates for pain, etc. So we now go back to that slide of complications. So there are various complications that can occur, arrhythmias, all sorts of arrhythmias, including bradyarrhythmias, heart failure acutely, cardiogenic shock. We can have rupture of the infarcted myocardium, which leads to several things. You can forget about those. You can have formation of aneurysms. You can have thrombi within the heart, and you can have pericarditis, either immediately or 2-3 weeks down the line, which is an autoimmune phenomena that we call Dressler syndrome. So we come then to the management of the complications. So if there are arrhythmias, there are various things you can do. We don't have time to go into details. If they have got bradyarrhythmias like heart block, pacing may be necessary. If they are in heart failure, cardiogenic shock, they are the necessary treatment. If you have the mechanical complications I talked about there, like rupture, etc., then the surgery to deal with that. The management does not end with the treatment of the acute infarction. It continues long term. The essence here is preventing another event. So the important things there, 1, risk factor management. 2, their pharmacological treatments we continue. So antiplatelets, initially we continue with the 2. After about a year or so, then we stop 1, continue with aspirin usually. We continue with statins lifelong. We continue with the beta blockers for a variable period and also ACE inhibitors. In a proportion of patients, we might need revascularization, just like we said earlier, and this can be either CI or bypass grafting. And then physical rehabilitation is extremely important. So that is management of STEMI. So how about the non-STEMI? Non-STEMI is when you have evidence of an acute coronary syndrome, but the ST segment is not elevated. And it basically incorporates 2 syndromes, which is one we call unstable angina, and the other one we call non-ST elevation myocardial infarction. The only difference between these 2 is that down here in the NSTEMI, we have biomarker evidence of myocardial necrosis, which in simple terms means that troponin is elevated. The upper one, it sounds exactly the same way, but there is no elevation of troponin. But we treat these 2 as a continuum of the same syndrome, the same disease process, and treat them basically the same. Just 1 minute. Bro, I'm giving a lecture. Let me call you in like 20 minutes. Okay, so pathogenesis is as for STEMI, so we won't repeat it. However, 2 important things. There is incomplete obstruction, and the clot, as I said earlier, is platelet rather than fibrin rich, and that leads to a fundamental difference in how we treat. Presentation is similar like for STEMI. So in the ECG, like I said, no ST elevation, so they may present with ST depression or Qwave inversion. And usually, if it's Nonstemi, unless it evolves into a STEMI, it does not progress to Qwaves. Biomarkers may be elevated, I've already alluded to that, and if the troponin is elevated, it's an Nonstemi. If it is not elevated, it is unstable angina. So in terms of treatment, the supportive management is the same. The antiplatelet treatment is the same. The statin treatment is the same. However, where there is no ST elevation, we do not use thrombolytics at all. So the antithrombotic treatment is between antiplatelets above, as we've already mentioned, and anticoagulation. So unfractionated heparin, low molecular weight heparin, sometimes use something called fundiparinax. And then we use an ischemic agent here, nitrates, calcium channel blockers, beta blockers, where necessary, and we won't go into the indications for invasive treatment. Again, we go for revascularization with either PCI or Maccabi, depending on the patient. And risk factor management, exactly the same principles. So we'll conclude by transmetal angina, which is a fairly very rare thing. Transmetal is actually somebody's name that is, as in many things in medicine, somebody's name was attached to it. It's also called variant angina or vsSpecific angina because it occurs due to actual coronary vasospasm. So the coronary artery goes into vasospasm. It often occurs in the portions of the coronary artery where there is actually some atherosclerosis going on. So it presents with the same typical anginal pain, but unlike the stable angina, which we talked about, which you remember we said the pain is precipitated by exercise or physical activity and resolves on rest. In this case, because it is due to the vasospasm, which occurs spontaneously, so the pain is spontaneous. The other difference with the stable angina is that in stable angina, during the ischemia, maybe I didn't mention that, if you do the ECG, there's ST depression. In fact, when we do an exercise test, that's what we look for. We look for, if we can provoke a significant ST depression. In variant angina, during the ischemic episode, there's actually ST elevation rather than depression. The treatment, because it's arterial vasospasm, we basically use vasodilators. So we use nitrates, calcium channel blockers. Now, you'll remember that beta blockers formed one of the cornerstone of stable angina. In variant or vasospastic angina, they are actually contraindicated because they provoke vasospasm. So those are the differences between a vasospastic angina and stable angina. And basically, that is it. So we've saved some time so that you guys can ask your questions. Okay, so we open for discussion, questions.
Professor, there's some questions in the chat box.
Let me see if I can get to the chat box. Let me stop here. So far, only two questions. You mean you guys are so many? I'm seeing 366 people. So, what do you mean? Now, hemodynamics, because I talked hemodynamics in many places. So, Brian, can you just specify in what context so that I know how to? You can actually unmute and talk.
The hemodynamic changes associated with ischemic heart disease, kindly.
Yeah, I suspect you are talking about it in the context of a myocardial infarction, where I mentioned the fact that the presentation is quite variable depending on the extent of the infarction. So let me give you two extreme examples. If you have a relatively young man, say a 45-year-old who has been having a fairly, normal heart in quotes, and gets a small inferior infarction, the only